All this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So FLCCC had asked me to participate in the long haul protocol. And for that, they had said that if I have a protocol, I can present that to them, or they can work with me to figure it out. So tomorrow we have a meeting where a number of doctors are coming together to put together the protocol. So I have never done anything over the year without the KoolBeens here. So I sent the protocol, but I wanted to go over that with the KoolBeens over here to see what did I miss. I'm sure I missed a lot because I just put that together today. So what did I miss? And just to review that protocol with you as well and get your feedback. And if you have any experience, if someone knows, for example, we have some KoolBeens here who are long haulers, or if you know someone who is a long hauler and has used various things that may have been useful, please tell us. And I was looking at the comments and I saw Frances comment that she would be able to help with the site to collect all this information here. So here, I would like to collect all the symptoms long haulers experience so I can start collecting data on Dr. B's website. Would anyone like to give me their list and their experience? So that would be amazing. France, if I can give you access to our website, and if you can create a small page where we can start defining what is long hauling itself, what are the possible pathologies and what are the symptoms, and then what are the treatment possibilities, that I think will be a lot of value for the KoolBeens and for the general public. So let's start. If you're ready, the meeting today is not for me to present to you, but really to go over what I have and then see what I can get from you as an input. So let's start. So this is Dr. Bean. Discord server continues to go on. I still love Dr. Corey's t-shirt. He asked me if it was making money. And I was actually surprised that there are so many t-shirts sold that I had not looked at Teespring for some time. So this is that, and let's start. So I hope you can see this screen of mine. Tell me if you can. I'm gonna turn this off. So can you see this screen with Dr. Mobeen Sayed and KoolBeens here? So let's see how I have put this together. Again, as you can see, this is a draft, and I have included your names anyways in it. So I have said Dr. Mobeen Sayed and KoolBeens. So you are participants. So I think it is in your own in your own interest to try to help me fix it. Otherwise, I'm going to say it is you. All right, so let's start. Possible causes. So viral hit and run leading to the immune dysregulation. And would you like me to explain these, or would you like me to just go over it and we can then discuss it separately? Hey, Margaret, how are you? So let's do this. I'm going to go over this, and then we'll come back and we would see if we can, if I need to explain some parts of it. So virus hit and run leading to the immune dysregulation. What that basically means is that when the viral infection is present and our bone marrow is making more and more cells, it is possible that some cells' gene expressions are altered, and their stem cells, because they're producing more cells in a rush, they can become altered, and it happens. Those cells that divide very often can become cancerous, for example. So maybe there is some mutation in them, and then those cells stay abnormal and keep making more cytokines and create a pro-inflammatory state. That's one possibility. In this possibility, the virus has gone, but the immune system is still just scratching its head and it's not on the right path. Second possibility, and it is possible there is a combination of all of those. Second possibility is viral persistence in monocytes. So this is Dr. Bruce Patterson and Dr. Yo's research that they said we have seen virus persisting in monocytes. Third is viral persistence in other tissues, for example, GIT. Mast cell activation syndrome itself. And in the way of mast cell activation syndrome, I would probably add here that this may also be systemic inflammatory response syndrome too, which would actually be if the virus is persisting or if the inflammatory system or the immune system has become abnormal. So this whole package of these symptoms can be put together in the systemic inflammatory response or chronic inflammatory response, which is like Lyme disease as well, which is like other chronic inflammatory disease, where sometimes we don't even know what are the solutions. It is also possible. Remember, we had looked at that study where the doctor was hypothesizing that it is possible that it happens to those who already have a baseline mast cell activation syndrome. They are not aware of it, and then when the COVID occurs, this syndrome becomes surfaced, and then they start experiencing that syndrome itself. So with this, the next disease target system, what I thought was important was that from a management point of view, not everyone who is a long hauler can be managed with the same medicine. And I have seen that by managing patients. There are some patients who have more neurological symptoms, and their management is different from those who have the rest of the system's symptoms. And then those who have the rest of the system's symptoms, they also have separate clusters, and there is possibility of managing differently. So what I did was I separated out the body's symptoms or clusters of the organs into neurological issues, GIT, respiratory, musculoskeletal, cardiovascular, and autonomic. For example, in the neurological symptoms set, there is the brain fog and the difficulty in concentration and focus, difficulty in focusing, being tired, being confused, and so on. So these are all neurological tinnitus. Then GIT symptoms, that continuous abnormal GIT situations. Respiratory system, shortness of breath. Musculoskeletal system, the fatigue and the myalgias and those kind of symptoms. Cardiovascular, tachycardia, POTS, the other such cardiovascular issues that may be seen. Autonomic nervous system, where vagal nerve abnormality and so on. So I thought the management of these are different. So one cannot give just one pill to everyone to say this is your solution. Although I would show that I think there is at least one area that there is one drug or two drugs that can be common for all of them. So we'll talk about them. Then is the disease course and pattern. And I haven't drawn this because this is something that I presented to Dr. Corey and Dr. Paul Marek and the rest of the team. So it had to be in a written form that they can look at. So this is why. So disease course and pattern. So what we have seen is so far with the long haulers that it could be hills and valleys. That is, the patient says, I'm okay 1 week, and the next week they're not. It could be persistent low intensity. So they're generally fine, but there is something, for example, let's say postural tachycardia, or let's say some confusion or brain fog. And they are able to start working in the day-to-day life, but they are reminded every so often that they have this going on. Then persistent high intensity. There are folks who have been experiencing long haul where they are unable to do things because they're just too, the symptoms are too bothersome. Temporary improvement with intervention and then reversing back. And then there are cases of permanent improvement as well. So note possible reasons for this. So this hills and valleys or change in variation in symptoms or patient experience are: the intervention is targeted towards the wrong pathology. So sometimes when we are trying to manage it, we are managing something else and the patient has something else. For example, let's say patient has neurological symptoms and they need fluvoxamine, but we are giving them ivermectin, which would not cross the blood-brain barrier and cannot affect the brain system needs. On the other hand, let's say somebody has GIT issues and we start giving fluvoxamine, that is going to work more on the brain tissue, and now the GIT symptoms will be there. Or, for example, if we give steroids to kind of suppress the inflammatory response, but when we stop steroids, the original inflammatory cause is still present, and that would cause the bounce back of the original symptoms. So the intervention is targeted towards the wrong pathology. Most interventions have anti-inflammatory medicine that makes the patient feel better anyways. possibility of multiple pathologies simultaneously present could also be a reason. So for management, and again, please realize that this is a work in progress. This is not an advice for anyone who is watching this. This is actually medical work happening. So please take it as that and help contribute to this. But this is not something that you see it and say, all right, I'm going to go home and start using this. Management considerations for doctors and nurses and nurse practitioners, physician assistants. Consider prophylaxis during the active disease. I think that is the most important part. Just like COVID should be treated, managed aggressively and early, similarly, an aggressive attempt should be made that patient does not become a long hauler by giving medicines that would help protect. So prophylaxis of long hauling should be done when the active disease is going on. Then neurological component isn't helped with the intervention targeted towards the rest of the system, and vice versa. And I explained it. For example, if somebody has neurological symptoms and they take ivermectin is not going to cross the blood-brain barrier and they would not get some relief from it. On the other hand, steroids can help. On the other hand, fluvoxamine can help. So the drug has to be targeted to the right tissues so that the correct therapy can be done. And doctor may have to figure it out. They give something for a week or 2 weeks and see if that works or not. If not, then they move on to the next system and then they try which system is responding, and that is where the problem is. I am sure that over time we'll have more labs, cheaper labs available, which would tell us in a better way that what exactly is the pathology and then work with that. I also do not want that this becomes like systemic response, systemic inflammatory response disease, where we still do not know what to do. I really think that in this push, when the pandemic is going on, we should figure out the solution now. There is one ray of light that I have, and that is that this disease, the chronic symptoms, I have seen in majority of the patients that they recover. Over time, they recover in general. So I think that this should be managed and this can be managed. So systemic illness needs a continued low-dose therapy for months before the patient can discontinue without symptoms reoccurring. So this is another thing that I've seen, that if you discontinue the therapy too early or reduce the dose or the frequency of the dose is not correct, then patient might respond, but the problem would reoccur. On the other hand, if it is continued for the right amount of time, then patient actually responds well. In some patients, pulse therapies on monthly basis work good. In others, continued therapy is needed. So I have seen in my cases that there were pulse therapies given twice and they worked fine. And then there are some patients who just need a continuous therapy. In majority of the cases, disease goes in remission over a long period of time, even without intervention. It is so funny for me to read this out. I'm not used to talking like this to read it, although majority of the people do it this way. I like to draw and talk. So please bear with me. The most disturbing and disabling feature of the disease is the neurological symptoms, making it difficult to focus and inability to work for normal hours. So I think some of the things are actually so disabling that patient cannot participate in normal life. And neurological symptoms are one of them. Cardiovascular system, especially palpitations, is another. Second set of disturbing symptoms are palpitations, pulsal hypertension, shortness of breath. So again, these messages are directed towards doctors to say, hey, when you are approaching a patient of long COVID, here are some of the things to consider. Then, barring a lack of good understanding of the pathology and a lack of the specific labs available, a provider must test various classes of interventions to home in to the pathology and address it. So a doctor has to figure out, let's say, start from the neurological symptoms, try to fix them, try to treat them, then move on to the next set. One should not start giving all the things at one time. Don't throw kitchen sink at the patient. Instead, go one by one to figure out where the actual problem is and then address that problem. Reduce pro-inflammatory state. So is it necessary that in addition to managing, should we reduce the pro-inflammatory state? For example, reduce the carbohydrate usage for some time? Should we reduce, for example, that day Dr. Tina Pierce said, reduce histamine enabling diets for some time, and so on. So should there be a diet change with it as well, where patient can actually go back to the normal diet that they liked, but for some time they change some diet as well? And then supplements, for example, NSE, NAD, CoQ10, B12, vitamin D, vitamin C. So what role should they play? I think they are important. So it may be that with the FLCCC's protocol, there may be these things not added, but in our own protocol, which France or maybe some other folks can help me as well, we can put that on Dr. Bean's site. And over there, we would add these two, because I believe in them. I believe in fish oil as well. I'm not saying they do not believe it, but I think that for FLCCC, it is important to have the backing up studies as well. Although I think they are now very much open to doctors' messaging as well, and doctors' experiences too, which is a good result. I think one thing that this pandemic is doing is it is teaching us that just the trial-based result is not sufficient. Doctors can make observations as well, and these should be used to help patients as well. Then labs. So I'm not very much clear on the labs yet. So generally pro-inflammatory state labs. So that would mean IL-6, that would mean IL-12, that may mean to do some neutrophil tests and so on. So generally MCAS related test, IL-6 test, IL-12 test, maybe fecal COVID test to see the remnants of for COVID, maybe bronchoalveolar lavage at some point. So this, I'm still working on this one. So now going into the management, once again, management here that I'm describing, this is not an advice for anyone. This is just a thinking. This is a draft of a potential new diseases management. So please, number one, don't take this as an advice. Number two, help provide some feedback to see how we can improve it, find out errors in this, and help me figure out how to improve. This is not the final deterministic management. The mixture here is of two things. One is my own experience. The second is the studies. There is a third thing as well, and that is people's feedback as well. So let's look at the back of the napkin management. And what I have done is, if you see on the left side, this is the active disease. So what to do in the active disease to reduce the chances for a long haul. So for example, do a prophylaxis, and that is ivermectin, steroids, vitamin D like things. So that is necessary during the disease to make sure patient does not end up in a long haul state. Then once the COVID is over, so in the post-COVID state, figure out, is the patient in the immune dysregulation, or is the patient in the virus persistence, or the patient may be in both. So if the patient is in immune dysregulation, are they in MCAS-like state, mast cell activation, or are they in non-MCAS, which might have macrophage activation syndrome, or may have other reasons? So for these, the management is different. And then if it is virus persistence, then see what needs to be done. And so for virus, so far, all we know is that we can give things like ivermectin, trifluvoxamine, and then optional vaccines, interferons, and IVIGs, and other such possibilities. So this is the back of the napkin. Check for the patient's IgGs, deficiencies, check for the vitamin D, check for MCAS, check for macrophage activation syndrome. I would love to add the T-cell test over here just to make sure the kind of response the patient has, the antibody test as well, just to make sure the kind of response patient has made, and then look at these things as well. So now let me present the management itself. So during the active disease, the red flags to observe 4. Again, this is a discussion with a doctor, with a provider, nurse practitioner, physician assistant, a nurse, a doctor. Red flags: observe slow improvement in the patients. Observe patients with past history of MCAS or allergies. Observe patients with comorbidities for which they are taking steroids or other immune modulating drugs. Age. Note, it does occur in healthy individuals as well. There are so many people who are long hauler who say we are perfectly fine. Actually, that is a majority. So For them, I still do not know what is the right red flag, but the ones that I could capture, I have put them here. Prophylaxis. So what do we do during the active disease? In the cytokine or the later phase of the disease, administer low-dose steroid therapy and ivermectin for prophylaxis. So imagine a patient is being treated for COVID, they are being given whatever medicines are being given, and then as they pass 6-7 days and you suspect that they may be moving towards uh, um, long haul, or you just want to make a standard protocol, just like with Dr. Sayed Heather. We talked and I said that, hey, we should use ivermectin, and he didn't do ivermectin on my asking, but he heard and then he started it. But then fluvoxamine is something that he talked with me, and he added steroids is something that he has added at the later part of his regime, and he has great results. So I think we should make it a protocol that near the end of the disease, after 6-7 days, we should give a small therapy of steroids and ivermectin to make sure that the patient does not end up in a long haul state. Inhaled steroids help prevent respiratory long haul state, so budesonide may be needed. Make sure that the vitamin D levels are correct. Make sure the NSE is there. Make sure the CoQ10 is there. So make sure those supplements are there. Make sure the previous pro-inflammatory state is not present. So these are the kind of things to do on the active side, active disease. Now, post-COVID, if the patient has actually now had COVID, come out of it, and then they report back in a couple of weeks and say, you know what, I have become fatigued, or I have. So post-COVID, the simplest thing to do is to give a pulse of steroid, and I've seen that working magically. So the closer it is to COVID, the faster that you can pick that up and treat it, the best it is. That means as part of the management of COVID, there should be a follow-up within 1 to 2 weeks with the patient to say, hey, are you doing okay? Do you have any myalgias? Do you have any neurological concentration, focus issue? Do you feel tired? Is your GIT okay? Are you having any breathing issues? Do you continue to feel feverish? They may not have fever, but they may feel feverish. And if so, then we give them a week pulse, a pulse of steroid for a week. That works like magic. What I've seen is that if the distance between the COVID symptoms, long haul symptom, and the COVID disease increases, then the reversal becomes longer. It takes more time. But the closer you can fix it, it becomes better. And this is a similar thing that with the prophylaxis of COVID itself. The early and aggressive treatment and the prophylaxis that we've done, the lesser the problems occur. Similarly, during the disease, the earlier we manage for long haul, the better it is. So post-COVID, if there are neurological clusters, so I've separated neurological from the rest because ivermectin, if it is used, it cannot help with the neurological symptoms. So that would need to be separately handled. So now, in the neurological symptoms, the patient could actually have two basic reasons. So keep those in mind. Number one, the patient may have MCAS, mast cell activation syndrome, or patient may have other reasons for the long haul. So if the patient has MCAS, they're not going to respond to fluvoxamine. So in that case, antihistamines will work. On the other hand, if patient has MCAS-like non-MCAS-like issues, pathologies which are not due to mast cell, then they respond very well to fluvoxamine. So that means if you have a patient who has neurological disturbance and you give them, let's say, fluvoxamine, and they say, no, it is not helping, then they may have MCAS-related issue and not the other way. So then try antihistamines with them. Similarly, the other thing, so over here, if you see, this would exclude autonomic nervous system issues, for example, postural tachycardia. Neurological clusters not MCAS related benefit from fluvoxamine. In MCAS group, fluvoxamine aggravates the symptoms, including causing tinnitus. Withdraw fluvoxamine and start with the antihistamines. So neurological clusters related to MCAS become aggravated with fluvoxamine, but respond very well to antihistamine. Over-the-counter F5-HTP serotonin supplements help reduce the symptoms as well. Neck massages to move the lymph from the cranial system, and the spinal cord pumping has been tremendously useful. It seems to be temporary. For example, when people start doing it, they feel relief. But if they stop doing it, then they bounce back. That means whatever is causing the inflammation and causing those fluids to accumulate, that is still there. So massages and pumping of the neck is actually helpful. Pumping of the spinal cord is helpful to keep the symptoms low, but the underlying cause has to be managed. Now, post COVID, non-neurological clusters, for example, shortness of breath, for example, GIT issues, for example, tiredness, for example, musculoskeletal issues, skin issues. There are so many kinds of issues that people have seen. So for them, number one, ivermectin. And ivermectin, so far what I've seen is weekly full dose. However, it may be necessary to do a loading ivermectin dosage and then go on weekly. For example, give ivermectin for 3 days, full dose, and then go on a weekly management. So ivermectin full dose. Now, ivermectin full dose, if you think about in the non-neurological symptom, the chart I had made, there is a possibility of virus persistence, and there is a possibility of immune dysregulation, and there is a possibility of both of them. So if that is the case, ivermectin will help with the virus persistence. That is the area that can also be helped by vaccine, that can also be helped by interferons. So ivermectin, vaccine, interferons can help with the possibility that the virus may be present. And I could, from a pathology point of view, for the doctors who are listening, nurses, NPs, PAs, this would mean that our immune system has gone in an energetic state. That means immune system is aware that the virus is there, but immune system says, you know what, I'm not bothered about it. So it's kind of a carrier state. So I haven't yet seen the carrier state with COVID. Maybe we should define this as a carrier state, where the patient has, normally in a carrier state, the patient themselves have very less symptoms or no symptoms. Here, the patients are victim of it as well. That is why calling it carrier does not look right. But behavior is similar. So that means interferons can help. That means ivermectin can help. And of course, most importantly, steroid. Ivermectin would take care of the side of the virus. Vaccine would take care of the side of the virus. Interferons would take care of the side of the virus. But if there is an inflammatory issue, immune system issue, then steroid would help with that. And I have put my own therapy here, prednisolone 5 milligram thrice a day for 3 days, then prednisolone 5 milligram twice a day for 3 days. Twice a day for 3 days. I used to give them for 2 days each, and I have extended that to 3 days here. Prednisolone 5 milligram once a day for 3 days and then stop. So a note here that there are some physicians who have been managing long COVID with a continuous low dose of steroid for months. That may be useful as well. I think it is not necessary. I think there are pulses that are needed, on top of which ivermectin can be a more continuous process. If stopping the steroid causes the symptoms to reoccur, then probable pathology is the persistence of the virus or MCAS and not the MAS or other immune hit and run issues. Pause on the steroids in such case. Pulse to confirm the possibility of the viral remnant or MCAS. Continue with ivermectin as it will help against the virus. Add antihistamines to start working against the MCAS. Now, based on the patient's situation, you might start with all of them, ivermectin plus steroid plus antihistamines, and then start withdrawing some of these to see where does patient become better, and withdrawing what drug, if we withdraw, the patient rebounces. If the patient rebounces, then that drug related therapy or this pathology is the one that patient is experiencing. Antihistamines may have to switch to various classes of antihistamine. Now, for antihistamine, this is very important that it is not necessary that one class of antihistamine always works for everyone or even for one person at all times. So you may have to switch antihistamines. So maybe 15 days one type and then 15 days another type and then continue switching, but keep the pressure on the system. Then post-COVID non-neurological clusters, continuing from the previous slide, if the GIT symptoms persist, then administer ivermectin on empty stomach. Ask the patient to stop using any high-dose vitamin Ds, do fecal test for COVID, and look at other reasons for GIT disturbance as well. Patient reports. So some of the reports that I have heard from the patients, for example, patient said that IgG deficiency. Then in another case, there was a patient who said that interferons had helped her very much. Then vaccines had helped as well. So these are anecdotal messages. There are no bigger clusters of patients who have been seen in that way. And then more to come. So this is where I think I am for the time being. Tell me, what do you think? And what is your feedback? Chuck Becker says, I'd feel solace if I lived near the hospital in which Dr. Bean treats Rona. There's no doc on the planet I would rather be treated for Rona than for long hauler than Dr. Bean. Thank you very much. I just wish you never get it. Correct, Rima. So even within H1, H2, there are classes. And I've seen that changing the classes actually works better for a patient. Sometimes you start giving, let's say, Allegra, and they would come back a week later and say, I felt better, but now I'm not feeling better. It's not that antihistamine has failed. It is that this class needs to be switched. So you change that. So not just another mother, also montelukast. Absolutely correct. So somebody should take notes. So montelukast, yes. I'm going to write here. So KoolBeens feedback. Montelukast. Okay, so that is done. Barbara says, Dr. Bean, you're brilliant as usual and so comprehensive in your analysis and recommendations. More importantly, you are open-minded and analytical. Thank you very much, Barbara. Tocilizumab, this is interesting. So if, for example, they come back very good, so I think it should be looked at. I'm going to write it down. For example, if they do the inflammatory profile and they come back and there is IL-6 like things that are increased, then tocilizumab would be interesting. Here is the discussion. The question is, what is causing the IL-6 to continue? If it is because there is a virus persistent or the immune system hit and run issue, then we have to kind of bounce the immune system by giving steroids. So I think that this is very important to add tocilizumab, but this would become maybe part of the test. So for example, when the patient comes in, give them this regime that includes ivermectin, toci, steroids. There were more things here that I've written. So once you've given them and see if the patient feels better, when they have felt better, antihistamines I meant, and then you start taking some of those off and then see how does patient respond. Generally, keep in mind, again, to the doctors, to the providers, NPs, PAs, nurses, if you're giving anti-inflammatories like steroids, patient is going to feel better because steroids' job is to reduce the immune system's responses and reduce inflammatory behavior. So they are going to report and say, I'm better. But it is that when you remove it, what would happen? So if you're going to bounce the immune system, you have to give it for long enough that the immune system have a rest and the stem cells may be able to go back to their reset default position. So good one. Potaristical XXX. Susan says, is ivermectin 1.87% pace for horses much different than the ivermectin 20 milligram? So Susan, the way Dr. Corey said, he said, we do not know what are the impurities in the animal brand ivermectin. I actually add one more issue to highlight there. Animal brand ivermectin has never been used on humans. So it has never been tested on humans. So we do not know that other impurities can cause what. Just like with the vaccine, we say there is an adjuvant, and that adjuvant may cause unnecessary things. Similarly, if we take animal brand grade product, I do not know what can happen because these are not tested. Because of that, I have always maintained that I do not wish that anybody takes animal grade product. So very good. Rima says, what about statins and anti-androgenics? It is possible. So I'm going to write them down as well. So statins and anti. Now, anti-androgenics will be interesting. Rima, what would be your, so statin, I can understand that they can help with the inflammation. Anti-androgenics, tell me, are you thinking that there may be estrogen, progesterone, testosterone increased? If that is the case, then there should be a lab for testosterone or androgen hormone test. So lab test for androgens. So Rima says protease inhibitors. Very good. I love this idea. Yes. So that would be bromhexin-like things, protease inhibitors. Dodi says, question, can you please add skin steroids and antihistamine for skin issues? I'm so glad you put antihistamines in the protocol. So antihistamines has to be there. So I would add this, that for skin issues, antihistamines. It's a topical. Arun says, there is a severe shortage of tocilizumab. Any substitute? I think you'll have to just search for IL-6 blockers and see what other brands are available. Samina says, please include reproductive health issues. So that is a very important one, reproductive health issues. So Christine says there's a brand that are pure ivermectin. Christine, I just put that up, for just putting it up. I won't comment on it. Susan Pick says, are you saying your doctor is a doctor of pharmacology? So Nancy says dosage for NSE for angina for long haul. So I have to yet put the dosage. I wanted to make sure that I have the basic draft ready, and now I'm going to put the dosage there as well. I would review that with the KoolBeens here. William Goff says, just curious, why no use of methylprednisolone by mouth for outpatient use if FSC tends to recommend it as preferred steroid? So I use prednisolone. It is short-lived. It is a pulse that I do for oral. Methylprednisolone might be fine as well if there is a respiratory reason. The reason FSCCC goes towards methylprednisolone is the availability in the lungs. So if that is the case, maybe that should be used. Otherwise, I have used prednisolone with great results. So I would think it is replaceable. And William Goff, thank you very much for the super chat. Rima says, Dr. Bean, I read a study that spironolactone seemed to have a preventative effect. They surmise it was due to protease inhibition. Very interesting. So, I have not seen this study for prevention. Is that prevention of the long haul or the prevention of the COVID? iFrog says colchicine. Colchicine has been great as well, yes. Stephen Westman says, could you comment on the paper role for MABs, if any, on the proper role of monoclonal antibodies, if any, only early stage? It's a very simple one. So let me get to Steve, if you can remind me this question a little later or maybe during the chit chat. I want to close this talk so that once again it stays digestible. So why not we do this? Let's close this one. I think I have gotten most of the feedback. And then let's do a chit chat as well so that this stays digestible. And here is famotidine. Famotidine, yes, I agree. Famotidine. Very good. Colin Hamill says, so I think YouTube is very angry with us for doing these kind of things. Colin Hamill, this will sound weird, but have any of the long haulers with neurological symptoms tried cannabis oil to lift their mood? So, okay, so let's stop for this one, and then we will get back in the chit chats. I see here Janet is saying spironolactones plus TMP SS2 are inhibition as a prophylaxis. That would be a beautiful prophylaxis. Agreed. All right. So please do me a favor. Please like, subscribe, and share. And if you would like to support this work, there are few links in the description. There is a link to buy me a coffee. There is a link to become a patron. There is a link to support this channel in general. So thank you very much. And I would see you shortly in a chit chat.